sorry. There is a cost effectiveness of screening of nasopharyngeal carcinoma with Epstein-Barr virus DNA in high incidence population globally. So that was the study. And this paper was from the University of Stanford, presented in the poster session and the last astronomy. We know that those patients, the incidence of endemic Epstein-Barr virus associated nasopharyngeal carcinoma varies worldwide. And those patients who present with early stage have a favorable 5-year survival of 90%. But most of the patients present at stage 3 or stage 4 disease. And screening trials have shown that using EBV specific serology or plasma DNA have detected most patients at an asymptomatic early stage. It is uncertain whether screening of nasopharyngeal carcinoma can be cost effective in specific countries and who to screen is with a given program. So we sought to define that the investigators sought to define the cost effective screening for carcinoma nasopharynx with EBV serology or plasma DNA PCR with or without MRI in high incidence populations worldwide. We know that for any screening, which it should be accessible, it should be cheap, and it should have a reduction in the survival, reduction in mortality, and so this should be cost effective. So what they have done was that they selected 67 cancer registries, and they selected and they screened them, and annual screening of men and female, it was done from 40 years until death, because the majority of the screening clinical trials, 3 clinical trials have used from 40 and 1 clinical trial have showed from 30 to 59. So 42 of the screened 67, the 42 high incidence regions that is spreading across 15 countries were selected with a lifetime risk of nasopharyngeal carcinoma more than 0.25. And individualized incidence rates based on region, age, sex, and ethnicity was recorded. And we know that the health adult, those patients who are screened, our intention is to find out the patients at early stage, stage 1. Then you prevent the mortality. That's our main aim. So what they have done was, when they analyzed, what is the data for them? Yes? Can I continue? Yes. The screening trials and strategies, if there is no screening, majority of the patient present at advanced disease. You can see that this is a paper published in Cancer in 2016. In healthy adults, we can see that those patients who are not screened, the proportion of patient present at stage 1 is very low, and majority of the patient present at stage 3 and stage 4. So this is a majority of patients. So our intention in high risk areas where there is endemic EBV and high chance for developing nasopharyngeal carcinoma, can we reduce the stage at presentation? So that is our conclusion. Then what is the data we have for screening of carcinoma nasopharynx? So this is one of the one paper that came in New England Journal of Medicine from the Hong Kong group. What they have done was the plasma EBV DNA PCR plus endoscopy and MRI was done. And in the same paper, they have done other the EBV DNA PCR and endoscopy without MRI was analyzed. What they have done, what they found out was that when the MRI was done, there is a slight increase in the stage 1 disease compared to the patients who didn't undergo MRI. And third paper, the last paper, that is published in Cancer way back in 1992. This has included a large number of patients. They analyzed the serum anti-VCA IgA antibody plus endoscopy, and you can see that when the patients were screened in endemic population, the stage 1 at presentation was more than 50%. It was around 60%. So this was the data where they pulled all this, and they have done based on the method that's a model clinical outcomes. And this is the data from the phase 3 clinical trial and from the AJCC 8th edition. You can see that those patients present at advanced stage have a poor outcome. So when they analyzed the results based on the screening, when no screening, this is the survival. This is the 5-year survival. You can see that it's 10-year survival. But when the patients who were screened, and the patients were screened with which modalities? The patients who have screened with ELISA plus endoscopy, the 5-year overall survival, then all the stages were clubbed together. It was 94%. And it is PCR plus endoscopy, it was 89. And when the MRI was added to PCR and endoscopy, it slightly increased by survival by 2%, that is 91%. And the reduction of nasopharyngeal carcinoma death, that is better with ELISA. These are all indirect comparisons, ELISA plus endoscopy. And this was 62 when the RT-PCR plus MRI plus endoscopy, that was 62. And when there was no MRI, the PCR plus endoscopy, the reduction in 5-year nasopharyngeal carcinoma death was 53%. And this was the 15 countries which they analyzed. And what they concluded from this, what they concluded was that the cost-effective screening strategies, based on that, the percent of regions cost-effective, based on what they analyzed from these regions, it was found that the ELISA plus antibody, that is 67%, and PCR plus endoscopy, that is 38%, and PCR plus MRI plus endoscopy, that is 40%. And the results, the most effective age to start screening was 40, although the paper published in Cancer in 1992 have started from 30 years. The screening as age as 30 was cost effective in high incidence regions. Then the results were most sensitive to the cost of regions and labor to perform the PCR in ELISA. The screening of both men and women were cost effective. And the conclusions, the screening of adult men and women with EBV serology of plasma DNA PCR reduced the mortality by 40 to 70%. In all regions, screening with serology was more cost effective than plasma DNA PCR. And screening was most cost effective in high incidence or high income regions. Addition of MRI to PCR screening increases cost, but small improvement in survival by 2%. And screening programs can be tailored to a given region's economic and demographic characteristics based on the cost, this one, and local policymakers may use this data when choosing the public health initiatives. Thank you very much for your patience.